This lecture is about psychocutaneous disorders, which are conditions that have both dermatologic and psychiatric characteristics. This is my outline. We will start by defining this group of disorders. Then we will go through the classification of the most common of these disorders, and finally we'll conclude with a few take-home messages. Psychodermatology refers to any aspect of dermatology in which psychological factors play a significant role. In other words, it's a field that deals with disorders relating to both psychiatry and dermatology. In fact, the incidence of psychiatric disorders among dermatological patients presenting to the clinic ranges between 30 to 60%, and often the dermatologist is the primary physician for such patients. A significant proportion of them resist referral to a mental health professional, and some even become offended if such a referral is suggested to them. Therefore, the dermatologist will have to face two choices. Try to address the psychological and psychiatric condition along with the skin issues, or ignore the psychological component of the patient's disease and focus only on the skin, which is not the optimal solution, as this commonly results in failure of treatment, dissatisfied patients, and doctor shopping. Keep in mind that the skin is the most visible organ, so the mildest disease may have mild psychological impact. And frequently patients with certain skin conditions elicit negative emotions from their surroundings. Skin changes are regarded as contagious or associated with sexually transmitted diseases. They may suggest inadequate hygiene, uncleanliness, and many a times are found to be unattractive. Unfortunately, modern media contributed tremendously to propagate unrealistic ideal body images. In the following slides, I will go over the most important entities we may encounter. But how do we classify them? There are many ways to classify them. The easiest is to group them into four broad categories. The primary psychiatric disorders. These are primarily a psychiatric disease where all skin manifestations are secondary and self-induced. The second group includes disfiguring skin diseases with secondary psychiatric disorders due to the resulting social and emotional distress. Depression, anxiety, and social phobia are most commonly observed. The third group includes psychophysiologic disorders, which are skin conditions that are characteristically affected, whether precipitated or exacerbated, by a psychological factor, such as stress and anxiety. And finally, the cutaneous sensory disorders. These are conditions in which the patient experiences unpleasant cutaneous sensory disturbances, such as pain, otherwise known as allodynia, or burning, itching, or stinging sensations, without a primary skin disease. The presence of a comorbid psychiatric disorder, such as depression, anxiety, or body image disturbances, can contribute to a heightened awareness of those abnormal cutaneous sensations. Therefore, these patients will often improve following treatment of the psychiatric disorder. We'll be discussing the first three groups, and we start with the first one, the primary psychiatric disorders. In this group, patients have primarily a psychiatric illness or condition which leads to skin problems. Okay, we have a variety of primary psychiatric disorders that we will be discussing, and we start with the first one, the delusional disorders. We will illustrate this category with the following case. A middle-aged woman presents with pruritus, stinging, and a crawling sensation. She even drops off a container in which she's been collecting over weeks carpet fluff and small fragments of wood, skin, or hair as evidence of what she considers remnants of bugs or worms that are supposedly infesting her skin. She clearly expresses dissatisfaction from her previous healthcare providers. On physical exam, she has excoriations, erosions, scabs, prurigo nodularis-like lesions, and ulcerations due to excessive picking at her skin. So how would you approach such a patient? The most important step here is to establish the diagnosis. Upon further questioning, you realize that this patient has an unshakable false conviction that her skin is infested by parasites. She compulsively self-mutilates while attempting to remove the non-existent parasite. This is consistent with what we refer to as delusions of parasitosis. This is a rare delusional disorder, most commonly affecting white middle-aged or older women. This is to differentiate from parasitophobia, which is the fear of becoming infested. On exam, as with our case, patients will have excoriations and sometimes ulcers, which, if chronic, would leave scars. They are frequently secondarily infected. Patients are usually doctor shoppers. They are angry and almost never satisfied from their doctors. They very quickly tend to establish purification rituals. They develop exaggerated and dangerous self and environment cleaning methods in the majority of cases. They use instruments such as magnifiers, tweezers, nail files, or simply their nails to dig into their skin. They may use a variety of chemicals, including alcohol, petroleum, kerosene, and gasoline, all this resulting in severe self-mutilation. They typically collect fragments of skin, hair, and other fomites in containers such as a folded piece of paper, plastic bags, cups, etc., supposedly containing the bug. This is what we refer to as the matchbox sign. So they would expect us to examine the specimens microscopically. That usually reveals keratin, so pieces of skin, crusted blood, hair, and clothing fibers, and obviously no bugs. On occasion, some patients would drop off a form to fill out. So what are causes of delusions of parasitosis? The most common type is the primary type, referred to as monosymptomatic hypochondrial psychosis. Patients have a single fixed delusion, so it is not secondary to another psychiatric disorder. Patients are usually intelligent, professionals, but often solitary and eccentric, and may have some obsessional personality disorder. We need to rule out secondary causes of delusions of parasitosis as well before labeling someone with primary monosymptomatic hypochondrial psychosis. Other psychiatric disorders that may manifest as delusions of parasitosis include schizophrenia, bipolar conditions, depression, and we must rule out illicit drug use because amphetamines and cocaine, especially in young patients, may lead to delusions of parasitosis as well as alcohol withdrawal. Cardiovascular accidents of the non-dominant hemisphere, multiple sclerosis, as well as vitamin deficiencies and severe renal disease and syphilis have all been associated with delusions of parasitosis. This is an example of a young adult presenting with delusions of parasitosis but found to be induced by methamphetamine. Therefore, always exclude drug abuse in a young patient. Now, when such patients present to us, we need to initially rule out actual infestation. And sometimes we might order screening labs to rule out organic causes for the delusion if deemed necessary. The approach to such patients is quite difficult and dealing with them isn't easy at all. Patients are convinced of their delusions. We should not try to confront them. It might be better to approach them in a way like saying, I can't see any of these parasites today. Because as mentioned earlier, they tend to reject initial referral to psychiatrists, and you need to keep them coming to the clinic so as to establish a good rapport and follow up with them. Otherwise, they will keep on doctor shopping. We need to foster trust. If the patient comes in with the so-called matchbox sign, better examine all specimens brought in. A skin biopsy might sometimes be required, however, the site should preferably be picked by the patient in order to avoid comments like, you biopsied the wrong area. Treating with permethrin or ivermectin on occasion in an attempt to get rid of the imaginary bug is acceptable. Ultimately, the patient has to be started on antipsychotics. Pimozide has long been considered as the treatment of choice, and SSRIs are helpful in cases of depression. In the end, a collaboration with a psychiatrist is very important in due time. Next, we will discuss the skin-picking disorders, otherwise known as simulated or self-inflicted diseases, and these include a variety of conditions. These are skin-picking disorders. They constitute 2% of dermatologic visits. They are more common in females. Ages range between 15 to 45 years, so the middle age group. There is often an underlying psychological disorder. Patients might have mood disorders, obsessive-compulsive disease, psychosis, or also rule out substance abuse. They lead usually to severe self-injuries. They lead to psychological distress as well, and to social and occupational impairment. We will discuss 5 main entities under this group, starting with dermatitis artifacta. This condition is produced by a variety of mechanical or chemical means: fingernails, sharp or blunt objects, lit cigarettes, caustic chemicals, to name a few. So lesions are very variable in their appearance. Lesions will have bizarre, irregular geometric shapes, not conform to any known dermatosis. They are clearly demarcated from surrounding normal skin. They usually appear in crops with an almost overnight appearance without any prior signs or symptoms. And sites are usually readily accessible to the patient's hands, like the face, hands, arms, and legs. Patients usually have a long history of psychological issues. Would their presentation be a form of emotional release in situations of distress or part of an attention-seeking behavior? Young female adults are more often affected, and many possess some superficial medical knowledge. The prognosis is best in young patients who need to draw attention to a particular problem. They tend to recover when the problem is solved. Again, here we need to avoid direct confrontation with the patient, who usually denies that the rash is self-induced. It is possible to infer that his/her activities are known, but regarded with understanding and sympathy. Ultimately, a collaboration with a psychiatrist is of great importance, as they need to be started on antipsychotic medications such as pimozide. And patients tend to resist referral to psychiatry initially, so as with delusions of parasitosis, we need to establish trust and good rapport. Hospitalization is required in cases of suicidal ideations. As for wound treatment, occlusive dressings are helpful. Next among the skin-picking disorders is the dermatologic pathomimicry. In dermatological pathomimicry, patients themselves cause recurrences or exacerbations of their existing skin disease. An example here is the patient who has celiac disease, so gluten intolerance, and known to develop skin rashes secondary to gluten ingestion. So the patient would have a gluten-rich diet on purpose to induce his lesions. Another example is the application of substances to the skin to which a patient is known to be allergic. Patients here are typically young women who normally receive little sympathy from within their families. In contradistinction to the previous entities, a direct confrontation here is often helpful in managing the condition. This is an entity that we commonly see, neurotic excoriations. Now imagine this woman presenting to your clinic with these lesions over the arms and upper back. Upon questioning, she admits to manipulating them and states that she is not able to get herself to stop scratching and digging into her skin until she injures herself. She seems unhappy and depressive. This whole picture is typical of what we refer to as a case of neurotic excoriation. This is by far the most common of the self-inflicted dermatoses. It mostly affects females. Patients readily admit to an uncontrollable urge to pick at their skin or some imperfections in their skin. They have compulsive scratching, digging most often at bedtime. They end up with greater irregularities than the lesions they started picking at. So they manipulate these even more, setting up a vicious cycle. Itching may or may not be present. Patients are more often depressed rather than having OCD or anxiety. They usually are hypersensitive and have lack of self-confidence. The management is difficult, again, with a multidisciplinary approach involving psychiatrists. So cognitive, behavioral therapy, and pharmacologic therapy with antidepressants are the mainstay of treatment. Somewhat similar to neurotic excoriations is acne excoriation. Acne excoriae is predominantly seen in females. There are two subgroups. Those with some primary acne lesions, these have a better prognosis. Once the acne is treated and patient educated properly, the condition resolves. Those with no acne lesions are more difficult to treat. These patients ultimately end up being taken in charge by a psychiatrist and started on medical therapy as well. The last entity we'll discuss in this group is trichotillomania. Let's look at this case. Here we have a 12-year-old girl complaining of patchy hair loss over the scalp since few months. She comes in with her mother and is in continuous disagreement with her. Upon further questioning, the mother describes a long-standing conflictual relationship between them. On exam, hairs of various lengths along with broken shafts are noted. What is the most likely diagnosis here? This picture is consistent with trichotillomania. Trichotillomania is a hair pulling disorder. So here we have rubbing, twirling, twisting, or simply pulling the hair, leading to areas of hair loss. This is an impulse control disorder, so patients recurrently fail to resist the impulse to manipulate the hairs. On exam, we typically see ill-defined patches of hair loss with broken hairs of various lengths with a normal scalp appearance. In iron deficiency or other nutritional disorders, the hairs become thinner but don't break at various levels as is seen in here. These findings, however, are not entirely specific to trichotillomania, and the diagnosis of trichotillomania should not be made when hair pulling is associated with a pre-existing skin disease or is in response to a delusion or hallucination. The hairline is often maintained, so the areas of hair loss are erratic compared to the hair loss we see with aging patients. Eyebrows, eyelashes, and beard may be affected. Children may ingest the hair that they pull out. Of course, a number of areas may be affected. We classify trichotillomania into two major groups. There is the milder type, which is more frequent in children, usually in females, but in the younger age group, it is more frequently seen in males. The act is partially conscious. It replaces thumb-sucking habit in a child, and it develops gradually and unconsciously and usually resolves over time. A history of emotional deprivation in the maternal relationship is often noted. The act is not usually denied by the patient. The more severe type is rare, with a predominance in adolescent females. Precipitating factors include school difficulties, sibling rivalries, dysfunctional mother-daughter relationship, or a traumatic move or any other stressful event. Here, the patients consistently deny touching their hair. The approach to the patient here is similar to previous conditions. We need to establish trust and rapport. Behavioral therapy is helpful along with psychiatric intervention. What makes the treatment more difficult is that the diagnosis is often rejected by the parents who have not observed the child pulling the hair. It is often unacceptable for them to believe that their child's problem is self-inflicted. Next, we'll be discussing a condition where the primary psychiatric problem is depression. In this category, we'll be discussing the psychogenic pruritus. We all have what we refer to as the traffic light phenomenon. You might have noted a motorist or driver, if not experienced yourself, scratching some body part such as the neck upon stopping at a red traffic light. Scratching is known to induce an ultimate feeling of pleasure, and this may be related to the release of opioids centrally. In turn, opioids induce more itch, so this sets in motion an itch-scratch cycle which gets out of hand in psychogenic pruritus. This diagram illustrates it better. An emotional event such as depression would trigger scratching, which induces opioid release, which would in turn result in a sense of pleasure. Opioids are pruritogenic, so they will potentiate the pruritus further, and more itch releases more opioids, and the cycle continues. A localized form of psychogenic pruritus is pruritus valvi, pruritus ani, and pruritus scroti, which we sometimes see in the clinic. These are mostly diagnoses of exclusion because we have to make sure that there are no organic causes for the itching. Furthermore, an underlying depression is often present in those patients, as I mentioned earlier in the diagram. And in fact, we see this in other dermatologic conditions as well. For example, patients with psoriasis who have some sort of depression, let's say, they might suffer from pruritus much more than patients who don't have the depressive condition. Now we move to phobic states. Okay, this is a large group of disorders. We'll just mention a few. Some patients present with phobia about dirt, bacteria, or viruses. This had been made worse with the advent of COVID infection. So patients present to us with hand eczema due to repeated and excessive hand washing. Patients may have phobia about warts, so they're afraid to touch anything in the consulting room or in the hospital, and they wear gloves when shopping, filling their car with gas, or any public area. Patients may have phobia about pigmented lesions. This has become much more common since the publicity campaigns for early diagnosis of malignant melanoma. So patients present with concerns over any small change or lesion that they noticed on their body. Patients may also have phobias of contracting sexually transmitted diseases like syphilis or HIV or others. They are often anxious, depressed, and have an obsessional personality trait. Finally, I'll mention a few words about this last entity among the primary psychiatric disorders, body dysmorphic disorder. This is a condition that we mentioned briefly. It's a preoccupation with non-existent or slight defects in physical appearance. So the patients here have a strong belief of looking abnormal, unattractive, ugly, or even deformed. And this leads to repetitive behaviors such as checking their appearance in the mirrors, and they're often unhappy with what they see. They seek dermatology or plastic surgery consults, and they want a lot of cosmetic procedures. This is a very common condition. However, it is under-recognized, unfortunately. It affects mostly females, mostly young people, and they often have an obsessive-compulsive trait, some mood disorders, and some patients have social phobia as well. This causes significant distress, impaired functioning on a social and professional level, and may lead to suicidal ideation and behavior. Very briefly, I will mention the other categories of psychocutaneous disorders. So, secondary psychiatric disorders result from the distress caused by disfiguring skin diseases, so mostly referring to depression, anxiety, and social phobia. So in other words here, it's the skin problems that are causing the psychiatric disorders. These are a few examples of some disfiguring skin lesions. You have patients with infantile hemangioma. So this may profoundly influence the emotional development of a child. It may affect the attitude of the parents towards the child, the teachers, and the peers also. So treatment is really required to alleviate the psychological burden. Another example of some disfiguring skin lesions that may occur in childhood as well, such as ichthyosis. Now we move to psychophysiologic disorders. Here, there is a constant interplay between the dermatologic conditions and the psychological state. In other words, the pre-existing skin condition may be stressful and have a profound emotional and psychological impact, such as anxiety and depression. And at the same time, the psychological state may, in turn, exacerbate the skin condition or even trigger it if not already present. Many conditions fall under this category, including atopic dermatitis, psoriasis, alopecia areata, to name a few. Acne vulgaris is common in teenagers as well as in adults, and this may be a handicap in development of relationships with peers. Patients may become depressive, increasingly introvert and solitary or even aggressive, and sometimes they are less successful at gaining employment. Hair loss, again, is another condition that is perceived as an illness, and patients become socially isolated with low self-esteem. Here are cases of frontal fibrosing alopecia, which we see usually with older age groups in women, and another patient with alopecia areata involving large areas of the scalp. Of course, these are not contagious and they are not harmful conditions. Psoriasis vulgaris is a very common condition that we frequently see in the clinic. It can present in a very mild form or very severe forms, and it can tremendously affect the well-being of the patient psychologically. The presence of relatively trivial amounts of psoriasis on the face or hands or any other body part in a patient may be as devastating as someone who has very extensive disease. Many studies highlighted the negative impact of psoriasis as well as many chronic diseases on the quality of life of patients. Activities of daily living become hard. And there are major repercussions on a psychological and social level, even leading in a minority of cases to depression and suicidal ideations. Like with most patients in this category, the feelings of embarrassment, shame, and low self-esteem are overwhelming. Patients benefit from a holistic approach targeting the skin problem and the comorbid psychiatric illnesses. Antidepressants are introduced with SSRIs as first line and TCAs for cases with pruritus. Conversely, some psychotropic medications are known to induce cutaneous reactions or exacerbate dermatologic conditions. There is a long list of medications leading to a variety of skin problems. I'll just mention a few entities. Phenothiazine antipsychotics, mostly chlorpromazine, are very notorious for producing a photosensitive reaction. The patients present with blue-gray metallic discoloration on some exposed areas of the skin, and of course the hidden areas are free of lesions. Lithium that is used for mood disorders is notorious to produce acneiform eruptions, and we have to be careful here because classically we tend to use tetracyclines for the treatment of acneiform eruptions, and in such a case it will lead to lithium toxicity, so we need to find alternative treatments. Lithium can also worsen the course of psoriasis. Finally, be aware that some of the treatments we use in dermatology may induce psychiatric disturbances. A few examples of medications inducing mood disorders include systemic steroids, methotrexate, and isotretinoin, whose relation to depression has long been debatable. Psychosis has been well reported with the use of hydroxychloroquine and dapsone. So in the end, psychodermatology is characterized by complex disorders where the skin and the mental state profoundly affect each other. This requires a multidisciplinary approach, so dermatologists and psychiatrists must closely collaborate in order to reach successful management of both the cutaneous problems and the mental state of patients. And always make sure you inquire about the medications patients are taking, as these may have a significant impact as well on skin and psyche.